All right, let's get right into it. If you're serious about becoming a vascular consultant, there are a handful of landmark trials you absolutely have to know inside and out. And let me tell you, the COMPASS trial, it's right at the top of that list. It really did change the game for how we protect our highest risk patients. So let's break it down, consultant style.
You know, for years, this was pretty much the core question. We'd put our patients on aspirin, a single antiplatelet drug, and hope for the best. It was our main line of defense. But deep down, especially for our really sick patients, the ones with widespread vascular disease, we all had this nagging feeling. This probably isn't enough, is it? And here's exactly why. A patient with peripheral artery disease, or PAD, doesn't just have a dodgy pipe in their leg. It's a system-wide plumbing problem. That plaque you see in their femoral artery, you can bet it's also lining their coronaries and their carotids, and that puts them at an incredibly high risk for the big, catastrophic events: a heart attack, a stroke, or losing a limb.
Which brings us to this absolutely crucial concept of residual risk. It means that even when we were doing everything by the book, aspirin, statins, blood pressure meds, our patients were still having heart attacks and strokes. The standard of care just wasn't cutting it. It was leaving this dangerous gap, and we desperately needed a better strategy to close it.
And this is where the COMPASS trial steps onto the stage. The researchers decided to ask a really bold question. What if we got more aggressive? Could a more powerful antithrombotic strategy finally plug that gap for these patients?
The whole idea was a two-pronged attack. Think about it like this. A blood clot forming is like a massive traffic jam on a highway. Aspirin, our antiplatelets, is like closing one on-ramp. That's good. But what if you could also block another major on-ramp, a totally different one? That's what adding a tiny dose of an anticoagulant, Rivaroxaban, does. You're hitting both platelets and the clotting cascade. It's a whole new level of traffic control.
And the way they tested this was just beautiful. I mean, this was a massive international trial. We're talking more than 7,400 P-day patients. And the design was rock solid. Randomized, double-blind, placebo-controlled, the gold standard. They put that dual therapy, a really low 2.5 milligram dose of Rivaroxaban twice a day plus aspirin, head-to-head against plain old aspirin alone. So what happened? Well, the results were so incredibly positive, so powerful, that the safety board actually had to stop the trial early. Now, as a savvy clinician, your ears should prick up at that. We know that stopping early can sometimes overestimate the benefit, and that's a key point for critical appraisal. But in this case, the benefit was just so clear that it was seen as unethical to keep giving patients aspirin alone. So here's the big headline number. For that primary outcome, the combination of cardiovascular death, stroke, or heart attack, the combo therapy slashed the risk by 28%. That's a huge relative risk reduction. In real terms, you need to treat about 77 patients for 2 years to stop one of these terrible events from happening. But for us, as vascular specialists, this next number is a one that really makes you sit up straight. A massive 46% reduction in major adverse limb events. We're talking about preventing acute limb ischemia and major amputations. This wasn't just about saving lives, it was about saving limbs. Just an incredible result.
Let's just look at those numbers in a different way. Over the course of the study, for every 100 patients just taking aspirin, 7 of them had a major cardiovascular event. In the group that got the combination therapy, that number dropped to 5. Now, a 2% difference might not sound like a lot, but when you scale that up across millions of patients, that is an absolutely massive public health win. Okay, but as we all know, there's no such thing as a free lunch in medicine. When you use a more powerful therapy to stop clots, there's always a price to pay. And that price is almost always an increased risk of bleeding. This is where the real consultant-level thinking comes in. And this slide really lays out the core conflict, the balancing act we have to perform every single day. On one side of the scale, you have this huge benefit: fewer strokes, fewer heart attacks, fewer amputations. On the other side, you have a definite increase in major bleeding. So how on earth do you make that call? This quote, right from the paper, is the absolute key to understanding the trial. It's the nuance that matters. Yes, major bleeding went up, but, and this is a huge but, there was no significant increase in the kinds of bleeding that we truly fear. The fatal bleeds, the bleeds into the brain. Most of the extra bleeding was manageable GI bleeding. That means the net clinical benefit was firmly on the side of the combination therapy. So what happens when a trial this big comes along?
with such a clear benefit and a manageable risk? Well, it doesn't just get talked about, it completely rewrites the rulebook. The evidence was just too powerful to ignore.
And here is the proof. All the major guidelines, ESVS, ESC, NICE, they were all updated to include these findings. But I want you to notice the key word here, selected. This is not for everyone. It's for carefully chosen, high-risk patients, often after they've had surgery or an intervention, and, crucially, who are at a low risk of bleeding to begin with.
Which brings us to the final, and I think the most practical part of this whole discussion. How do we actually apply this in the clinic with a real patient sitting in front of us? The trial gives us the science, but it doesn't give us a simple recipe. It gives us a new, powerful tool for personalized medicine. At the end of the day, it all comes down to this one word: individualization. Your job as a consultant isn't just to quote the trial stats, it's to be a master of applying them. COMPASS isn't a one-size-fits-all solution. It actually demands that we get much, much better at figuring out who's who. So for every patient you see, you're running through a mental checklist, just like this one. How bad is their disease? Have they had a bypass? What's their bleeding risk look like? How are their kidneys? How frail are they? And, just as important, what does the patient actually want after you sit down and explain all the pros and cons? That's the art of medicine, guided by the science of COMPASS. And so, that's what COMPASS leaves us with. It's a fundamental shift in our thinking. It proved that for the right patient, that high ischemic risk, low bleeding risk patient, our old way of doing things just isn't good enough anymore. It forces us to ask this question for every single person we treat.